Speaking to specialist psychiatrist Dr. Musheri Wangombe on dementia. What exactly is it? Who does it affect? Who is at risk? And you will be able to ask questions. We'll have our numbers on your screen in just a moment. Feel free to call in and ask a question, give a comment, or can also interact with us under the hashtag Weekend Express at KTN News, or tweet me directly at Michelle Ngele. Dr. Musheri, thank you so much for joining us in studio this morning.
You're welcome.
Right. So we've been keeping tabs on mental health issues, especially in Kenya. It's a very taboo subject. But today we're speaking about dementia. What is dementia?
Dementia is defined as a chronic, progressive, degenerative condition which affects one's thinking, communication, and memory. Yes.
Okay, so what's the difference? Many people associate dementia with Alzheimer's disease. Are they one and the same? Are they different?
There are many types of dementia, and Alzheimer's disease is the most common.
Right.
It accounts for 60 to 80% of all dementias. We also have other dementias like vascular dementias, which are caused by as complications of hypertension. We have Parkinson's disease. We have what is called a frontotemporal dementia.
Right.
So it affects the frontal part of the brain. We have dementias that result from deposition of proteins, like what is called Lewy's body disease and Huntington's disease.
Right.
Yes.
So those are all types of dementia.
Yes.
So what is some of the signs and symptoms then that a person would exude if they had dementia?
Somebody with dementia will, depending on the stage of dementia, there are various stages of dementia. So we start with what is called mild cognitive impairment. In mild cognitive impairment, you find that this person keeps forgetting things. They place something somewhere and they can't remember where it is. And then it proceeds then to mild dementia, where they get more and more forgetful. Then as they continue to moderate and severe dementia, that is when you find that they're not able to express themselves. In addition to not being able to express themselves, in severe dementia, you may have difficulties in swallowing, difficulties controlling bowels, and they may need to be assisted with eating. They may need to be assisted with eating, bathing, and activities of daily living.
Right, so they pretty much can't do much for themselves.
Exactly.
But let's begin with that first stage, placing something here and forgetting it. Most of us forget things every day. Is that a sign, that we're, in the first stage of dementia? Or is that just normal?
No, that could be associated with lack of concentration. Maybe somebody who is a bit anxious, somebody who is tired.
Right.
It's late afternoon, the person is tired, then they may tend to misplace things. But this tends to be progressive. It's something that starts slowly, then suddenly you find that it has gone out of control. Then what happens with dementia is that this person starts by forgetting things that are short-term.
Right.
They can remember what they did in childhood, but ask them what they had for breakfast, they don't know at all. In fact, most of them will say that their caregiver does not give them any food, or there is no food in this house.
Right.
Yet they have just had a meal as you watched. Yes.
Okay, so dementia, of course, affects those who have the dementia themselves, but also affects their families and those close to them. In many cases with dementia, people end up forgetting even their own families, and these are the very same people that have to take care of you. So how do people who have relatives or friends with dementia then cope with that?
First of all, it's important for me to say that for the patients and their relatives to cope, it's important that we first make the diagnosis, and the diagnosis is made early. So what are the predisposing factors to, for example, Alzheimer's disease or any kind of dementia? There are those we call non-modifiable factors, and there are those that we call modifiable. So the non-modifiable include genetic predisposition.
Right.
Alzheimer's does run in families. You can't find the mother, the daughters, the sons. You have a whole family that has features of, or they suffer from Alzheimer's disease. Then alcohol can also predispose somebody to dementia, and traumatic brain injuries can also predispose one to dementia. Those are the non-modifiable factors. What about those that we can control? Include hypertension, diabetes. They include depression, for example, and treatment with various medications that may predispose you to the condition. Yes.
Right, so then who gets dementia? Is it something everybody is prone to get, or is it just for the old age? Who gets dementia?
Dementia is more common. Actually, 5 to 7% of the aging population above 65, they suffer from dementia. But recently, or as research has shown, even people in their 30s, 40s have started developing dementia, especially when it comes to alcohol-related, as a complication of hypertension, diabetes, those vascular dementias, and also HIV-associated dementia.
All right. So we don't have much talk about dementia in Kenya, for example, and especially when you speak about old age, people in Kenya and Africa mostly think, you know, dementia, forgetfulness, and, you know, other symptoms of dementia are just old age. You're just aging. They don't really associate it with a medical disease. How far has Kenya gone in combating dementia and creating awareness for that?
As far as creating awareness, we are doing our best, trying to ensure that everybody is aware that dementia is a condition that is chronic, progressive, and preventable in some instances, where you have the modifiable factors, like, for example, diabetes, hypertension, the depression. Then if you regularly exercised, then that would prevent your likelihood of developing dementia. Lifestyle modification, healthy eating, then also what we call mind gym. If you're doing code word, Sudoku.
Mind gym, that's an interesting term.
Crossword.
Yeah.
If, for example, you're doing puzzles, if you keep your brain busy, then you're less likely to develop dementia. You know, it's important to mention that studies have shown that dementia is more common among people of low academic achievement. Right. So then the hype we have of going back to school is very much in order to make sure that we also do not catch up. I mean, dementia does not catch up with us. Right.
There's another study I came across that said your chances of getting dementia are also lower if you marry a partner who's very intelligent. So does that apply?
I have not come across any randomized clinical trials that have confirmed that, because then you would, besides the fact that the person is intelligent, then you would have to look for other confounding factors that probably the fact that maybe you're not diabetic, you're not hypertensive, you're not using alcohol, you don't have a genetic predisposition, or you have not had any traumatic brain injury. There are many other factors that we would have to look into for us to say cause and effect. Like, for example, we say cigarette smoking causes lung cancer. Those are patients who've been, or these are studies where patients were recruited, they were followed up over several years, including more than 15 years, for us to say the cause of lung cancer is cigarette smoking, or cigarette smoking causes lung cancer. So that, I think, is homework for me.
Right, absolutely. Yes. So another study here from the UK says in the UK, 61% of women are prone to dementia as opposed to 35% of men. So why is that? Is that because women are more prone to getting dementia, or is it because women live longer than men, generally?
Women do live longer than men, generally, but also the fact that women are more in the population than males may have an effect on that. And then you find this more lifestyle diseases, the hypertension, diabetes. Some of the studies have shown prevalence in, I would say, in either of the sexes. So depending on what is the cause of dementia, whether it's a vascular dementia or it's Parkinson's disease, then that would really affect. But I don't have any statistics on male vis-a-vis women, especially in our context.
Right, okay. Yes. So then when one has dementia, what treatment or therapies are available for them?
first is to find out, to make the diagnosis. So should you find that there is somebody who has been progressively losing their memory, they've been unable to communicate, sometimes they can't follow conversations, then that is the time to take them to see a doctor and find out what exactly could be the problem. There are 3 simple questions we can ask someone to do. Like we can ask you to name 3 objects. You name the 3 objects and we ask you to repeat. Maybe we can start with you. I ask you to name.
Flower, table, and carpet.
Okay, fine. And then I ask you to draw a clock. So then, after that, I ask you, please name for me the objects that I asked you to.
So if I can't name them,
if you can't name them, then that means then you have a problem with acquiring new information.
Let me just prove that. I said flower, table, and carpet. So let me prove it.
Thank you.
I can remember what I said. Yes. All right, so let's talk about, there's been a debate, especially in the US, of people with dementia driving.
Yes.
Yes. What is the situation with that? Are they in good shape to drive? Is it recommended for maybe the early stages of dementia?
I would want to say that this is something we should think about. Especially, there are some patients we make who will be brought to you when either they were found to be in a roundabout, going round and round and round and round, and a police officer just stopped them. What exactly is happening? Because the person can't tell which was the way home.
Right.
They're just going round and round. We've also had patients where they drive and drive and drive until the car runs out of fuel. They can't quite tell where they were going.
Right.
So driving when you have dementia is dangerous, both for yourself and for other motorists and pedestrians who are walking on the road. But sometimes that's the only way people get to know, because what happens is the person keeps forgetting, but says this is procedural learning.
Right.
This is procedural memory. I'll never forget how to swim. So how can I forget how to drive? Then you find them driving, but ideally they are not supposed to drive. Yes.
Okay, so let's talk about personal changes with dementia. Of course, a lot of changes happen. What kind of personality changes do we witness in patients with dementia?
First of all, if you have frontal dementias, frontotemporal dementias, the frontal part of the brain is this, the temporal part is this.
Right.
So then if you have frontotemporal dementia, you tend to have personality changes. You will have, like for example, you may become disinhibited. You are somebody who used to talk, now you don't talk. Then you may get social withdrawal. Others do also get depressed. Especially in Parkinson's disease, we found there is a high rate of depression. Then there's something else called pseudobulbar affect, where you just have short outbursts of laughing or crying for no good reason at all. But these are conditions that can be managed. So the other thing about the behavioral changes that happen, people tend to hallucinate. As I spoke last time, maybe I can say again, that we say we have 5 senses. So we see, we smell, we taste, we hear, we touch. So you can hallucinate in any of those. So you can start, usually they see small babies who are crying next to them, and they may hear voices of people who talk. They may feel like there are things crawling under the skin. Then they also get deluded. They're the people who will be shouting at night at the top of their voices that those guys are coming to kill me. They are coming to kill me. Look at them.
And it's
then
very real to them.
Sleep. For them, it's real. A hallucination or a delusion, for them, is real. Yes.
Okay. So let's before we even get to caring for someone with dementia, how does it affect the patient themselves? When they realize they really can't do anything for themselves, they keep forgetting their way home, they can't drive anymore. How does it affect them?
In mild cognitive impairment, in mild dementia, they get very, very frustrated. Because they want to cover up all the time for the memory loss. You ask them which day of the week it is, they have no idea. You ask them where they are, they have no idea.
Right.
You might ask them who is accompanying them. Maybe it's the daughter, the son, the sister. They have no idea who they are. it can get quite frustrating, and they have relentless efforts to cover up for their memory deficits. So for them, it's usually quite frustrating, and they get quite agitated. Sometimes they won't want to be reminded to shower. They won't want anybody to assist them. They won't want to wear a diaper. And you have been incontinent. I mean, you have been in control of your life all along.
Right.
Then now suddenly it's
As an
diaper
adult,
time.
yeah.
No, it's very frustrating. When they get to severe dementia, unfortunately, they're not able, they don't understand anything.
Right.
So, I mean, they don't know whether it's day or night. Once you keep the food for them there, I mean, they feed one spoon, they forget there was food.
Really?
Yes, they just forget.
Wow.
They're the same ones who will be saying, the caregiver now has been stealing my money. So what happens is, they want to keep their money safely, but they can't remember.
Right.
So the person with them in the house is the thief. Yes, so they keep changing caregivers one after the other before you realize, well, what is happening here?
Yeah, then I can imagine that it's very frustrating as well to be the caregiver to somebody with dementia, especially like you said, when somebody can't remember their own child, then it must be very hard for the families to understand. So what should people keep in mind? What kind of care should we give to patients with dementia?
The first thing is, the best would be to have the patient in their home environment. I must mention that these patients sometimes won't even remember where the loo was.
Right.
So you might have to do some signage to show them where the toilet is. If they leave the toilet, they may not remember to go back to the bedroom or to the living room or whatever. They may not be able to name something. So as much as possible, we would like that the families are involved from the stage of diagnosis, so that they get to understand, what is this dementia? They get to understand that this is a lifelong, progressive illness and associated with regression of milestones. So what we are trying to say is that this person is no longer the independent person you knew, the independent mom who took care of you, or dad who took care of you, who drove you to school. Now things have changed. So you may also need a lot of counseling, you need a lot of support in terms of support groups for carers of people with dementia. And then sometimes the person has a matchbox, but they don't know what to do with it.
Right. Then
it's important that such people are not allowed to cook for themselves. Otherwise, then they're going to burn the whole house.
So then patients with dementia need full-time care?
Depending on the stage, especially from moderate, especially severe dementia, they need a 24/7, 365 caregiver.
Wow.
Yes.
Okay. Let's talk about some myths associated with dementia. One myth says that coconut oil, using coconut oil, I don't know how to use it, but using coconut oil reverses dementia. Is that possible? Is it even true?
One, I would beg to differ with that, whether it's applying it or drinking it.
Cooking with it?
Yeah, because dementia is a progressive, degenerative disease. It has no reverse gear.
Right.
The only thing we can do is to improve the quality of life and to make sure these people are able to function socially and occupationally, in terms of they're able to relate with members of their family, they're not a danger to themselves or other people. That's all we can do. Okay. So coconut oil is a big no.
A big no, yeah, because people will be consuming it in large quantities. But let's get to the details, because dementia is a general word for several other, different illnesses. So I just want us to get into some of the symptoms of those illnesses. Are they general? If someone with the Parkinson's disease and someone with the Alzheimer's disease, do they have the same symptoms, or is it different?
It's different.
All right, so let's speak about Alzheimer's disease to begin with. What are the symptoms of Alzheimer's?
Okay, Alzheimer's disease, being a dementia, is characterized by difficulty in thinking, difficulty in communicating, and memory loss. The reason why it is lumped together with Parkinson's disease is because in Parkinson's disease you also have memory loss.
Right.
So what we're trying to say is that Alzheimer's disease is the most common type of dementia, affecting 60 to 80%.
Right.
But it will have the symptoms like I described in terms of the mild cognitive impairment, mild dementia, moderate and severe. When we go to Parkinson's disease, it has other symptoms now. Like for example, you have rigidity. People tend to be very rigid and it affects the way they walk. They're not able to walk straight,
Right.
and they're not able, sometimes they're not able to maintain balance. They also have, they have slowness in doing tasks,
Right.
like repetitive movements. If you ask them to tap the finger, they'll not be able to do that. And then also, in addition to that, they do have what is called a resting tremor. So when they are seated, you will see them like a half shaking of one hand or one leg on one side. But once they touch something, the tremor goes.
Really?
Yes.
All right. Let's speak about this other, I don't know if it's a myth, but it's something that says patients with dementia lack empathy. So especially when it comes to maybe a spouse that has dementia and the other spouse tries to be very, affective, to show affection, and the patient, just pushes them away. They don't want anything to do with that kind of affection. Is that something that's common with patients with dementia?
Yes, it is common, especially when it comes to the frontotemporal dementias. And remember, this person, depending on the stage of dementia, some of them don't even know who this spouse is.
Yeah.
So what is this about affection?
Right.
Who are you? How can I tell whether you're a stranger or not? So it has a few, I would say it's not just about the emotional bit. As I said, they tend to have emotional incontinence, like I said, in pseudobulbar affect, where they will laugh, like they have short bursts of laughter, which are uncontrollable, and basically they're not in tandem with how they feel, with their mood, so to speak, because mood is a subjective feeling. That is how I feel. Then affect is what you observe. But now for those ones, they are laughing, but they're not happy. They're just laughing. It's what I'm calling emotional dysregulation or incontinence. So there are many factors that can affect the fact that this person lacks, is not able to be receptive to any emotions or any love. They may be hugged, but what is a hug?
They're just there.
They're just there.
Right.
So it's a sorry state.
Okay, okay, very sorry state. Now you say patients with dementia should be kept within their home environment.
Yes.
But, like I said, when such symptoms start showing, people think this person is crazy, You're just either very old or just totally crazy, and they take you to a mental institution. Why is that not recommended? Because people would think, I have to go to work. I don't have the capacity to give full-time care to this person. So you confine them to a mental institution.
It is wrong just because someone is above 65 years or is in their 30s and is behaving abnormally, either they're hallucinating, deluded, and a diagnosis of dementia has been made, you take them to a mental institution.
Right.
Why would it be wrong? Remember, we said it's irreversible. If there is no reverse gear, what is the mental institution going to do for this person?
Right.
The only thing that may happen, if then they are a danger to themselves or others, they may need a short-term admission for them to be given injectable medication, for the agitation to reduce, for them to be stabilized on medication, which then they will use later. Because again, old people are tricky. Remember, the kidneys are also wary, the heart. You need to be very careful with the dosages that you give them. And then some of the medication may also cause confusion. So then it's better to manage them for a short time in probably a general hospital where they can have scans. They have investigations like a CT scan or MRI. They have thyroid function tests, because somebody with abnormal thyroid levels, like I said last time, would be Low thyroid levels, they tend to manifest with features of depression. High thyroid levels, they tend to manifest with features of anxiety. So it's important to rule out the physical or the medical causes of the same the same conditions. But having said that, in the long term, it's important that you have the person, if they were a farmer and they were living up country, they should be able to be taken out in the sun, they see their goats, they see their cows. I mean, in that environment where they know once they're shown the toilet, it is this side, they keep being reminded it is this side, you may have to keep taking them.
Right.
In other countries, like in the Netherlands, they have a dementia village.
Right.
As you said, there are people who are very busy, they are working, and then that is another option. But in our setting, you can always get a caregiver.
Right.
Even if you'll get one who does 12 hours, another one who does 12 hours, then you make it a daily routine that there is a caregiver on a daily basis for this person to be fed, to be bathed, to be taken out in the sunshine, to have a walk. Remember, the fact that they're very old, if they're then in bed all day, then that can predispose them to other problems like clots in the legs. Clots in the legs can dislodge and go to the lungs, which we don't want to talk about that here.
Right.
So then there are many other things that can happen when somebody is in bed all day doing nothing. So they need to be kept busy. Then remember, these people can get lost.
Right. So don't leave them alone.
So you need a watchful eye. So if you're going to the ladies, you need to make sure they're in a place, they're just at a place where you can actually see them. Otherwise, that might be the last time you see them.
Right.
Or they may be knocked by a vehicle. If you have a compound, the better, so that you lock the gate. So that they're somehow, they're just maybe within the compound and don't leave the compound.
Right.
Yes.
Okay. So it's, you know, an irreversible situation. So the
Exactly.
best thing that would be prevention. Let's talk about the lifestyle choices that we make earlier on in life that then predisposes to dementia later on. Is lack of sleep one of them?
Yes, it
Tell
is
us
one
about
of
that.
them. So it's important that in addition to what I said, brain gym, making sure your brain is active,
Right.
you have at least 8 hours of sleep every day. Very important.
8 hours. You know, most people don't get that.
Yes. Now with the Nairobi traffic, you have to get up at 4:30 a.m.
Right.
to get to work at 8. Then with the traffic
Back.
then you have to get there at 10. You have to do a few chores, maybe homework, and then you find yourself, it's midnight, so you sleep 4 hours only per day. Then you're predisposing yourself
To dementia.
to many mental health problems, I must say.
Wow.
Not just dementia. Yeah.
Okay, well, that's something people need to keep an eye on. But then what else other than that? How can we prevent dementia, so to speak?
Remember what I talked about, modifiable factors? Diabetes, if diabetes is kept in control so that the person eats right, takes their medication as prescribed, regular visits to their doctor, the same with hypertension.
Right.
If depression is treated early, if, for example, as we said about enough sleep, and things like infections like HIV, they should be treated and treated early so that you don't have the low CD4 count, which then leads to many other conditions, neuropsychiatric manifestations of HIV, and HIV-associated dementia is one of them.
Okay.
Yes.
Right. So we have one of our viewers earlier on was asking, is it possible that dementia can affect your vision instead of your memory?
Vision, no, unless there is another underlying condition. Usually what happens, even if it's frontotemporal, the vision area is in the occipital part, that's the back of the head.
Right.
So it wouldn't really affect your vision. I would advise that the person gets checked, an eye check, because with age, people get cataracts. Cataracts are opacities in the lens, so then you're not able to see. And cataracts, it's actually a day procedure.
Right.
They can be excised, and you're able to see. Yes.
All right, so we have another one here asking, my hands are constantly shaking, you know, and I don't know why. Could that be a sign of dementia?
One, it's not possible just from the shaking of the hands is not really a symptom of dementia. Dementia, we said, has to do with your thinking, your ability to communicate, and memory loss.
Right.
I would like the person evaluated by the nearest health provider as to why they are shaking. Could it be anxiety, or could it be a thyroid problem? And depending on what age they are, then the clinician will decide what are the best investigations for them and the way forward.
Right.
But tremors alone cannot be a diagnosis of dementia. Yes.
All right. Now, we're talking about, you know, going to the nearest health center and the 3 questions that you ask, but is that the only type of screening, the only screening rather for dementia?
No.
Especially for the different types?
No, there are many other screening. There are physical examinations, there are neurological exams that can be performed by your doctor. This was just an example to probably tell the public that this problem is something you can diagnose or is something that you can tell. If you're not able to form new memories, then that calls for some immediate attention. So the tests are available, but they need to be conducted by a professional.
Okay, all right. Now we've spoken, you know, just demystifying it, we've spoken about the different types of dementia and how they manifest themselves. But and I understand that the different types also have different causes.
Yes.
All right, so let's speak about that. Just if you could just take us through those, the causes of the different types, especially Alzheimer's and Parkinson's, the most common. What causes those?
Alzheimer's disease is hereditary.
Oh, yes.
It runs in families. So when we talk about the cause of Alzheimer's, we would more or less talk about the genetic predisposition,
Right.
and it's the most common. Then we have conditions like Huntington's disease. It also manifests with some abnormal movements
Right.
and dementia and features of dementia. It also runs in families. Then if it is alcohol related, it's caused by alcohol. If it's vascular dementia, it has to do with strokes. So somebody who got a stroke could be caused by either lack of blood supply to a certain area of the brain or because of bleeding to a certain area of the brain. It is more common to have lack of blood supply, what is called ischemic strokes. They are more common.
Right.
How do you diagnose them? You just suddenly you discover one side of the body is weak, or you can't use it. Then that is what it takes for a diagnosis of a stroke. You need to go to hospital, needs to be evaluated, and you need to be started on treatment. If it's something like Lewy body disease, then you need to do some tests so that you're able to find out whether to differentiate it from other dementias.
Right.
So usually the tests are to look for an underlying cause, 2, to differentiate the various types of dementias, and also for us to plan treatment. Yes.
All right. So let's speak about the very fact that dementia mostly affects people at old age, 65 and above.
Yes.
But we did speak of people maybe age of 30, I don't know if maybe late 20s that get dementia. What is it that predisposes the younger people to that?
Usually alcohol use, 2, infections, like we said, HIV. And usually it's infections and alcohol.
And the very fact that like Alzheimer's, for example, is hereditary, does that mean that it can manifest itself much earlier in your life?
Yes, it can. Yes, it can.
All right.
Yes.
Okay. All right. So let's speak about, even as we wind up, let's speak about the Kenyan situation. As a psychiatrist, of course, you deal with the issues of dementia like this. Are Kenyans, when it comes to caregiving, are Kenyans on the right track dealing with patients with dementia?
Okay, from experiential evidence, not really. We haven't done any studies for that, which probably we can cite. But the Kenyans are very willing to take care of their old people, especially the fact that I think apart from Nyumba ya Wazee in Kasarani, we don't have many of the facilities, which is an advantage on our part.
Because they get to stay at home.
So they get to stay at home. Otherwise, then if we had many of the Nyumba ya Wazee, then you would find most of, the clients being dumped there, which is rather unfair. Usually, I would say, as opposed to other countries, the cost of labor here is not too much. So then it's a viable option that you can have a caregiver 24/7, 365. So that is something that works for us. Then we find that most of the relatives, once they are well psychoeducated on the diagnosis, the cause of the illness, and the prognosis, it takes time. Of course, it does affect them. They need a lot of counseling, but they're able to embrace that, and they're able to make modifications in the home. If somebody was living in a flat, probably they get them a home where there's a bungalow, there's some compound, where they can, they're free to be mobile without a lot of restrictions, and of course without risks of things like falls. So then our population is more receptive to that. Of course, as I said, it's a process. It takes quite a while for you to accept that this is what is happening, and nothing else is an option.
It cannot be reversed.
It can be reversed.
Okay.
The only thing we have is sometimes there's that stage of denial such that, yes, this person has a job, but now suddenly they can't, like for example, if they were working in a certain organization, they now can't work. Then now it becomes difficult when now the person was a breadwinner, then you're now asking them to retire on medical grounds. Then now the wife was the one who was hustling, she was probably doing some casual job. Now she also has to stop to take care of this person, because you see, if you have a casual job, you may not afford to hire somebody else to then take care of this person 24/7.
So it puts a strain on families as well.
It is a big strain on the families. So it actually depends on, for example, the financial capability, but it is actually a strain on the families. And if we could prevent dementia, then probably that would be the only way forward.
If you can do it, if you can prevent it, do it now.
Do it now, yes.
Right.
So start doing Sudoku just after this.
Absolutely, I will. So Dr. Mushari Wangombe, thank you so much for joining us in studio today. She is a specialist psychiatrist, and speaking to us today about dementia, a mental health issue that affects people mostly over the age of 65. Yes, this is the Weekend Express. My name is Michelle Ngele. Have a good morning.